Well, it's my pleasure to introduce our next speaker. Dr. Katie Gilbert-Spear is a healthcare attorney and optometrist. She graduated with honors from Auburn University with a degree in biomedical sciences and obtained a master's degree in public health and epidemiology from UAB Public School of Public Health. She earned her doctor of optometry from UAB, and in 2019, she graduated from Mitchell Hamline School of Law with her Juris Doctorate degree with a concentration in health law and compliance. She is a licensed attorney in Florida, Alabama, and Tennessee. So it's my pleasure to turn it over to you, Dr. Gilbert-Spear.
Thank you for the introduction. I'm super excited to be here today to talk to y'all a little bit about keratoconus, the new standard of care, and the referral process. Before we get started, a few housekeeping measures. Just want to take a few seconds to look over the important safety information, make sure all the attorneys are happy. So just take a few seconds just to read that. And then also a disclaimer slide. As you mentioned, I am a healthcare attorney, but nothing that I say today should be construed as legal advice. Okay, so let's talk a little bit about keratoconus today. We all know as optometrists that keratoconus is a sight-threatening, underdiagnosed, and underdetected disease. What's exciting is that prior to 2016, we really didn't have a whole lot of treatment to prevent progression of keratoconus. But in 2016, with the approval of iLink corneal crosslinking, we now have a chance to treat our patients and actually slow or halt progression of keratoconus. And let me go back real quick to that slide. 70% of keratoconus patients actually present to our offices first. So we're on the first line treatment for keratoconus patients. And so we may need to make sure that we are abreast of current standards of care and treatment as they change. So today we're going to discuss diagnosing keratoconus and how that's changed, failure to refer for corneal crosslinking, and then what is unapproved crosslinking, because that comes up a lot. Let's start with diagnosing keratoconus. This is an interesting study of almost 400 patients, or 722 eyes. It showed that only 13% of keratoconus patients were diagnosed before the age of 18, and approximately 70% had reached stage 2 of the disease before they were actually diagnosed. And as I stated before, that's okay, or I mean, it's not ideal, but it's not a huge problem if we don't have a way to actually slow the progression of keratoconus. But now that we actually have iLink corneal crosslinking, we need to ensure that when we see patients with keratoconus, we diagnose it early. And we'll talk a little more about that in a little bit. So the standard of care of keratoconus is changing. Partly because of the FDA approval of corneal crosslinking in 2016. Let's talk about standard of care for just a minute. Standard of care changes throughout a course of a disease as we get new treatments. From a medical legal standpoint, when we're looking at standard of care, it used to be that standard of care was determined jurisdictionally. For instance, if I'm in a rural area, I may not have current treatments, or I may not know about current treatments as early as someone who's practicing in a city who has a lot of, resources available to them. That's changing a little bit now because of the internet and because we have knowledge right at our fingertips. But from a medical legal standpoint, when we look at standard of care, most of the time, in the medical legal arena, cases don't really make it to the court system. They typically are settled before they get to a court. But if you do make it to court with a medical legal case, a judge is going to look at the standard of care, and that standard of care usually comes from published guidelines for that disease. And so why that's important is because in 2018, the American Academy of Ophthalmology changed their preferred practice pattern in regards to keratoconus. Before that, there was no really early treatment, early standard of care. And now in 2018, so almost 5 years ago, they changed their preferred practice patterns to state that we need to diagnose keratoconus early. And when we see any type of progression of keratoconus, we need to refer those patients for corneal cross-linking earlier rather than later. So changing those preferred practice guidelines essentially starts changing the standard of care. And we know that if we delay diagnosing keratoconus patients and actually intervening in a timely manner, that about 20% or 1 in 5 patients may require corneal transplant. So it's imperative that we diagnose these patients early and then know what to do once we've diagnosed them. So this study right here came in 2011, so it's a little dated, but like I said, it's really hard to kind of get data on medical malpractice claims because typically they don't make it to the court system. They're usually settled. So the numbers that we actually have from medical malpractice claims usually come from medical malpractice carriers themselves. They'll usually do an assessment of their closed claims or paid claims to see, what gets doctors in trouble. And this was actually a study done in 2011 of optometry specific malpractice claims. And it showed that 55% of malpractice claims in optometry actually come from misdiagnosis. Misdiagnosis for keratoconus looks like a lot of things, just regular old astigmatism, myopia, dry eye, and corneal lens warpage. The key here, and the reason I'm pointing this out, is that we need to have a process to diagnose these patients. So if we are suspicious for keratoconus or any disease for that matter, we need to make sure that we are looking for these patients and diagnosing them in a timely manner. Just because we may not have, a topographer or a tomographer doesn't mean that we don't have the skill set to diagnose these patients. And even if we don't manage keratoconus patients, it's still on us as optometrists to ensure that we are diagnosing them. I equate it to glaucoma. Every optometrist screens for glaucoma on every single patient, and we should be doing the same thing for keratoconus patients. This is an interesting study of closed claims for ophthalmology practices, and it showed that the failure to timely diagnose a patient was actually not the result of a lack of clinical judgment or medical expertise. It was the result it was the failure of following up on a test result, a missed appointment, or a telephone message. And really it results in, or it comes from miscommunication or a breakdown in communication between the practice itself and the practice and another medical practice. It's really important to have a process in your practice to mitigate this risk. You want to make sure that when you diagnose a patient with keratoconus or any other disease, you have a process to treating those patients. You have a process to managing those patients and referring those patients when needed. Now, the failure to follow up on a test result internally is just a breakdown in communication. And there are some processes that I have in my own practice to help with that, such as at the end of the day, I look at my list of patients, and if I've done testing, I make sure that I actually go back and look at those tests and document it in the chart. Also, when we print out a testing, an OCT, a topography, or whatever it is, if it's not signed by the doctor, then it doesn't get scanned in the system. And so they know that the doctor has to look at it, sign off on it before it actually gets put into the record. So some important tools for your practice. I love what Glaukos has for topographers and autorefractors. This is the autorefraction card. I actually have this on my autorefractors in my practices. It's really helpful for your technicians and your staff to help you in identifying suspicious patients. For example, we have this card on there, and if my technician sees a patient with, a lot of seal, greater than 2 diopters, steep K over 47, it's a red flag to us to call my attention to this patient. And so they'll write something on the little fee slip that says, hey, look at this. I'm getting an error message in the autorefract, or this looks really weird. It's just another way to call my attention to a potentially suspicious patient. They also have a great topography card too. Once again, just a good tool for you to identify these patients, or actually really involving your staff to help you identify these patients early. So we're going to move on from diagnosing to referring for corneal crosslinking. So progression, we know that keratoconus is a progressive disease. And an interesting study that came out during COVID was we were shut down for 3 months in COVID, that 100% of the patients who were unable to get into the office within a 3-month period of time, actually 100% of those patients progressed. In another study of pediatric patients, 88% of them who did not undergo corneal crosslinking within 12 months progressed. We know that keratoconus is a progressive disease. It progresses differently for different patients, but patients will progress. So that's why it's important to diagnose it early and to get treatment, corneal crosslinking treatment, when necessary. So let's talk a little bit about our risk in referrals. Typically, as optometrists, when we refer a patient to an ophthalmologist or another physician, once we've made the proper referral, we don't really have, a lot of liability in that, because we're referring them to board certified, highly trained, specialized physicians. It's interesting. This is a study that they did of several medical practices, large and small. And the managers of these practices said that 53% of their risk comes from referrals. And it's not making the right referral, it was actually failing to follow up or schedule the right referral. And what this looks like a lot of times is, when a patient may refuse to schedule it, or they want to schedule it themselves and then they don't, and then they fall through the cracks, or we get it scheduled for them and then they never show up, and we lost them to follow up. And 5 years later, we say, oh my gosh, we referred that patient, but they never actually made it to the appointment, that they never came back in with us. And we don't oftentimes have a lot of good documentation to say, hey, I told you you needed to go to this referral. And if you don't go to it, then, you could progress, or your condition could get worse. So in the referral, make sure that you actually have a referral process. And one thing I want to talk about before I get to my referral process is the AAO's preferred practice pattern. I just want to point out here that it says, waiting for additional loss of best corrected vision or progression in patients with ectasia should be avoided whenever possible. Referral is appropriate in this situation. So it is important that, one, diagnose the patient early, because if we see progression, we need to refer them for corneal crosslinking so that they don't progress too much and then end up with potentially having, a corneal transplant. So what does the referral process look like? And this is for anything that you refer a patient out for. Think about how that works in your office. Do you have one person that's actually making the appointment? Do you have multiple people that make the appointment? Do you give it to the patient to make the appointment? You just need to be consistent and understand what works best for your practice. In my office, what happens, I have one person, one staff member in each office that's responsible for referrals. We actually have a binder in our office. I'm sure there's some high-tech way that it could probably be processed and tracked better, but we like our binders. We actually have every doctor that we refer to, we have them tabbed out, and then we have a running list. So every time we refer a patient, we put that patient's name down, we put what we're referring them to, and when we made the appointment. And then here's the key. We make sure after that patient was seen, the next week we follow up to see if we didn't get the notes back. Usually most of our doctors that we refer to actually send us notes back pretty consistently and early, usually within a couple of days after the appointment. But if for some reason we don't have the notes back, then we go and we call the doctor and ask for those notes. And then and sometimes if the patient didn't make it, they'll tell us the patient rescheduled or the patient no-showed. And then that allows us to go to the patient and say, okay, we told you that you needed this appointment. Why didn't you go? How can we help you? And really, it's about documentation. You want to make sure that you document that you educated the patient on what the referral was for, why it was needed, and the risk if the patient doesn't actually go to the referral. And make sure it's done every doctor, every patient, every time. But documentation is the key. Now, I don't know if it has happened to you in your office, but it certainly has happened to me in mine. I've had patients that actually refused to go to the doctor that I wanted to refer them to, whether it be, usually it's location, like they don't want to travel that far. Sometimes it happens where a patient's in my office and I want to do more testing, and maybe their insurance doesn't cover it, and so they refuse the testing. We have a form that we fill out when the patient refuses what we are educating them that they need, so that we don't bear the risk of them not having the referral or them not actually doing the testing that we recommend. I will tell you that if a patient consistently refuses to do what I ask them to do as far as treatment and follow-ups and testing, then I will usually end up terminating my relationship with the patient, because I think that it's just a risk. And if I want to make sure that the patients that I have, they respect what I'm wanting to do for them as far as treatment and follow up. So you can do that however you want to in your own office. I would just caution you that make sure you're documenting it anytime a patient refuses a referral or a treatment for whatever reason that may be. And then this is the letter we send. So for example, if a patient refuses to go to the referral that I want them to go to, or a patient refuses to come back in and see us, or we just can't get them scheduled, they refuse to answer the phone. Sometimes that happens. We actually will send them a certified letter. We give them 3 attempts, and then we send a certified letter saying we've attempted to contact you. It's very important as far as your eye condition that you follow up regularly. This is why. And then if we get no response from the certified letter that we send, then we terminate our relationship with the patient. And just make sure that when you do terminate your relationship with a patient, that you do it appropriately, because there are laws around that. And depending on your jurisdiction, and maybe like I know that ours, we need to send a certified letter. We also have to see them within a certain time frame. We give them a certain amount of months to actually be seen in our office if they have an emergency or they have something come up. But we also have to give them 3 different doctors around our area that they could go to, that we could send their records to. So that's a little different in every jurisdiction. So just make sure that you're following the laws of where you are, and make sure you document it. Documentation is always the key. So let's move on to unapproved crosslinking, because there's a lot of confusion in this. So I just want to go through each one of these for you. So corneal crosslinking, iLink corneal crosslinking, is the only FDA-approved corneal crosslinking in this country. Like I said, it got approved in 2016. So the difference between an FDA-approved treatment and off-label is if you take an FDA-approved treatment, a drug or a procedure, and you use it for something that it was not approved for, that would be using it off-label. A lot of times physicians do this with different medications. So maybe the medication got approved for heartburn, and they're going to use it for, I don't know, something else. And so it would be like if for corneal crosslinking, iLink corneal crosslinking procedure, if for some reason they used that for something other than, corneal ectasia, you're using something that's approved, but you're using it in a disease that it wasn't approved for. And physicians typically have the ability to do that. What's different in corneal crosslinking that's happening right now in this country is that there is corneal crosslinking that is non-FDA approved. So it is not the iLink procedure, and it's not off-label. It is something that has never been through any FDA studies to show its safety and effectiveness. So The reason that I bring this up is because it happens a lot around this country. And when we refer to a physician, a doctor who we know or should know or is presenting, unapproved FDA treatment to our patients, then we could bear liability in that. So let's look at a couple of studies here. The reason that this is concerning is because we know that the unapproved corneal cross-linking typically leads to progression. So in one study, you can see 50% of pediatric patients, so this is kids, and that's a whole other level of malpractice risk the pediatric population is. So 50% of pediatric patients who were treated with the non-FDA approved corneal cross-linking had to be retreated with FDA approved or iLink corneal cross-linking due to deterioration in all parameters after 12 months of follow-up. That is very concerning, because if you are the doctor who's referring those patients to an ophthalmologist who provides non-FDA approved corneal cross-linking, and then the patient actually has to be cross-linked again, we could bear some liability in that. So let me go back to this real quick. So any drug combination for cross-linking that your patients are being presented with that's not iLink is not FDA approved. And like I said before, with most referrals, we're sending them to physicians or ophthalmologists, who are board certified. They're providing the latest and greatest treatment. I equate this to kind of like if you had a retinal physician that you were sending your patients to, and they were still doing, only laser treatment for macular edema. We would not send that patient to that physician again, because we know that first line treatment is usually injections, and we know that works very well. So you've got to be careful of what your patients are being presented with when they actually get to the doctor you've referred them to. And so I encourage you to ask the doctor, whoever you're referring to, ask them, call them up and ask them what type of corneal cross-linking are they using in their office. Go and look at it for yourself, see what your patients are going to be presented with, and then ask your patients afterwards. A big red flag may be, I think 95% of insurance plans actually are covering corneal cross-linking, but if it's not an FDA approved corneal cross-linking, then insurance companies won't cover it. So if your patients go to an ophthalmologist and are offered corneal cross-linking, and they come back and tell you that their insurance won't cover it, it should be a red flag for you, because most insurance companies are. Just some considerations on referrals. We have a duty to exercise reasonable care in referring a patient to another physician. We actually have to know that physician is using current approved treatment, providing the correct standard of care. And if you look at ilinkphysician.com, they actually have a nice website. You can type in your area and see who is providing FDA approved corneal cross-linking. And also, obviously, you have a rep, so reaching out to the rep and seeing who they recommend is helpful too. So in conclusion, it's not the actual referral itself. As long as we're managing our referrals of our patients, correctly, following them, tracking them, ensuring that they actually make it to the referral, then we usually don't have a lot of liability in that. But if we are consistently referring to someone who's providing our patients with treatments that's not FDA approved, then we could face liability down the road. So I just want to encourage you to make sure you know who you're referring your patients to, and also make sure you have a process to follow up with them. All right, any questions?
Well, that was a great presentation. There are a few questions that were asked. So, is there a procedural difference between on-label and off-label cross-linking um, that makes on-label superior, aside from liability due to approval?
Well, we know, well, the epi-off is the current FDA approved cross-linking. The non-FDA approved that's being used is epi-on. I think a lot of people would say that, okay, well, I like the epi-on because it's, it's not as painful for the patient. It's not, but it's not been FDA approved as safe and effective. So regardless of if the patient, may be more uncomfortable, that's not our concern, I would say. It's more of keeping the patient safe and referring them for a treatment that we know has been well studied and shown to be safe and effective.
Gotcha. And then what degree of liability would you have if you send a patient and they do not receive FDA-approved cross-linking, either knowingly or unknowingly? Meaning, in some cases, you may be in a more rural area where they don't have access to FDA-approved cross-linking, and they end up at a provider that does off-label, or potentially they go on their own to a provider that is doing non-FDA approved and end up going that route.
Mm-hmm. So there is no off-label with corneal cross-linking. It's just not approved. It's either approved or not approved. There's no off-label with corneal cross-linking. But so even if the patient has to travel longer, I think that educating the patient that this is the one that I recommend you get, and this is why. Now, once the patient's out of your hands, you can't force them to do something or not do something. So I would just make sure that I had it documented in the patient record that I educated them, one, on the differences, and that two, their insurance should cover it. So if for some reason they made it to someone that I did not refer them to, let's say I referred them to someone who is 2 hours away because I know that they're providing FDA approved cross-linking, and they say, no, I want to go to this person because they're only an hour away. As long as you document that you educated them on the risk and the why and all that, then your liability is minimal. It's when we fail to properly educate, and usually we educate, it's just we're not very good at documenting sometimes. So it's just really the documentation that really helps us mitigate our liability.
Is there any specific verbiage to be used in our EHR or charts about the referral to an FDA-approved cross-linking site? Can it be as simple as just saying referred to this provider for FDA-approved cross-linking?
I think it's just as simple as that. My thing is I always like to make sure with any patient that I am concerned about progression, so for any disease, I want to make sure that I put in the chart that I educated them. Failure to follow up with appropriate, time, in timely manner or whatever could cause progression and visual damage, or blindness, or, I really like to make sure that I educate the patient and I document that. I think the malpractice cases that I've been involved in, usually it's not the doctor's failure to educate. They just didn't put in there that they educated. And one I can think of was the patient sued the doctor because he said he lost his vision from glaucoma because he never actually came back. But he said he sued because the doctor never told him he could go blind. He just said that may have glaucoma, but he never told him that he could go blind. And if your chart doesn't say that, then it's you didn't really educate the patient on how risky it was if he didn't follow up. So I think similarly with keratoconus, especially because we know that it progresses and it can result in needing a corneal transplant. If you diagnose somebody with it and then you want to follow them appropriately. So with proper documentation that, hey, this is progressive. And if you fail to come back, I've got some patients I want to see back in 3 months, 6 months, depending on how I'm following them. because when we see progression, I want to make sure that we get you seen for the treatment in a timely manner. And if we don't, you will get worse,
Well, we appreciate your time. I think that's all the time we have for today. And so with that, we will end this session.
Thank you.